started. So for people who don't know, I'm a new faculty, new transplant from the University of Pittsburgh. My name is Priya, and I am a sleep researcher as well as pulmonary critical care. I gave a talk last year about my research in sleep health and people with HIV, and also about different plausible mechanisms by which chronic inflammatory pathways may overlap in the setting of HIV. But I wanted to take a step back today for this talk and really talk about sleep disorders in people living with HIV in more clinical sense. I geared this talk more towards talking about the prevalence of sleep disorders, kind of some similarities and differences in pathophysiology between sleep disorders in HIV versus in people without HIV, and the clinical consequences of poor sleep in HIV. Yeah, I didn't put slides in about treatment, but certainly if we have time today, we can certainly talk about improving treatment and management of people with HIV, of their sleep disorders. And so I tried to keep this talk a little bit shorter, but I think that the information is quite dense. So we'll see, how far along that we can get today. And so, the first thing to know about people living with HIV is that the prevalence of sleep disturbances and sleep complaints in this population is extremely high. So there's different ways to measure sleep health. You can use symptomatology like sleepiness, fatigue. You can use subjective measures of sleep quality. And you can also look at objective measures of sleep with actigraphy and home sleep apnea or polysomnography type of studies. But generally, in all of these different various ways of measuring sleep health, we find that people living with HIV have a very, very high prevalence of fatigue, have a very high prevalence of sleepiness, and have a really high prevalence of poor sleep quality, disrupted rest activity rhythms, and sleep apnea. And those are the conditions that I'll be talking more in depth with today. And in the era of antiretroviral therapy, we're seeing that people living with HIV do continue to have poor sleep health, although the mechanisms by which that is due to may be different now than when the literature first came out, in the 80s and 90s. And so we'll be taking a look at kind of the more modern person with HIV who's more likely, greater than age 50, who's been on antiretroviral therapy for years and has, from looking at it kind of medically controlled.
Oh, sorry, Priya. You have not shared your screen yet.
Oh, no, I've just been talking at myself for a little bit.
Yeah, we
My
thought
bad.
Introduction, and then but it kind of like you went in already. Yeah.
Sorry about that, y'all.
Here we go.
Okay. Can you guys still see my screen? There's like a green line on half of it.
Yeah, it has to do with the resizing. That's fine.
Okay, but they can see the entire slide. Okay.
We cannot see the entire slide.
Try stop and reshare. I think it's time to just reshare. Because you're still in the presentation, but this way.
Gotcha. If we do this one,
Either way.
share.
There.
Okay, this one looks like it's going through now.
The only thing you might want to take the video with it is the yeah, just because it may be blocking.
Gotcha.
Yeah, if you can pull that to the top. Yeah, there we go. Now it's
okay. And so firstly, we're going to talk about sleep quality. And so it's hard to get a true measure of insomnia in the research cohort of people living with HIV, generally, we can't get a clinical definition of insomnia, which would be, greater than, bothersome sleep or trouble sleeping for, 3 times a week, greater than 3 months, et cetera, et cetera. But so generally we'll get certain positives on questionnaires and positives with the Pittsburgh Sleep Quality Index. And so there have been a lot of associations with poor sleep quality and the impact of that in people with HIV. And in one study done in 2011, people living with HIV who complained about a great deal of bother with falling asleep or staying asleep had 42% greater odds of not actually adhering to their HIV medication. They had greater odds of depression and suicide, of unemployment, illicit substances, and having HIV viremia. And you could see how this relationship is both can be exacerbated by sleep, but can also come around and affect sleep quality, right? So if you're unemployed and have unstable housing, how that may relate back to having, poor sleep quality. And certainly having uncontrolled HIV viremia would also worsen your fatigue and your sleep quality if you have this, underlying uncontrolled infection. And so what we have seen, in several studies now, is that poor sleep quality certainly has a association with depression, which appears additive to HIV status. And we've seen this both in men as well as women. And so this study here, using the multi center AIDS cohort study, which followed 2,500 participants, was limited to men. And they had answered the CESD, which is a questionnaire asking questions to assess levels of depression. And they did this both in HIV positive men as well as in men who have sex with men at risk for HIV, but HIV negative. And so you can see on this graph here, the dotted lines are people with sleep disturbance, and the solid lines are those without sleep disturbance. The red being people with HIV, and the blue being people without HIV. And so far and away, people with HIV with a sleep disturbance have the greatest incidence of depression as measured by the CSD, and compared to when and all these participants had a negative CESD when they were initially followed. And so,
That's a good question.
Yeah.
What's the vertical axis?
So this is the number of
Just number, just number.
just number.
What age was the cohort started? About? Do you know?
You mean the age of the cohort?
Yeah.
Generally the max cohort has been middle-aged, so around age 40, 50, but I actually don't know the number off the top of my head. I can definitely look that.
Yeah, I just don't know what that looks like in a non-HIV prone population. It's just really remarkable.
Yeah. And so, and this is with, this is in the population of men who have sex with men. So, certainly they have more risk of different, environmental and social stigmas. And so, so with people with HIV who have a sleep disturbance, they certainly had a higher incidence of depression compared to people with HIV without a sleep disturbance. And then if you look at the people without HIV with the sleep disturbance, they also had the highest risk, second to people with HIV, of a sleep disturbance. So having a sleep disturbance at the onset at baseline was certainly a predictive risk factor for having depression, developing depression later on. And then you can also see that there's a positive interaction between the HIV status along with the sleep disturbance, although the sleep disturbance by itself appears to be the worst predictive factor here. We did see similar findings in the women's cohort, and they measured both depression, measured by the CSD as well as anxiety. And so they measured poor sleep in this study by the Pittsburgh Sleep Quality Index greater than 5. And again, they used the CESD, the 16 threshold, and the GAD-7 for anxiety. And so you can see that people with poor sleep had a higher incidence of depression compared to people with better sleep, and the odds ratio of that was almost 6. And similarly with anxiety, they had a higher incidence of anxiety, also around 6 as well. Viremia also played a significant role. And so people who were viremic, women who were viremic, had higher incidence of depression and anxiety compared to people who were well controlled. However, this was still, and these rates were seem more similar amongst the women. Amongst veterans, there was a study done that asked veterans at baseline if they had difficulty falling asleep or staying asleep using a 5-point scale, from no difficulty to bothers a lot. And they measured the incidence of cardiovascular events using IC9 codes of acute MI, stroke, or CABG. And so they had a median of about 11 years follow-up from the study. And so you can see that the bothers a lot, the people who had the most frequently bothersome sleep, these people were the most at risk of developing a cardiovascular event by the end of the follow-up period of 12 years. And this was about 60% greater risk than those who had no difficulty falling asleep or non-bothersome sleep. Did you have a question?
No, it's 2 and 4 years, 2 and 4 years.
Yeah, it's
It's not-
quite a
it's
precipitous
not-
drop after 6
I mean,
years.
the vertical axis was 8.
But still, I think that's a really high
That's 1 out
number.
of 20.
But then when you talk about cardiovascular outcomes, that's really significant.
Well, I always peg it to cholesterol, which is
Although I did learn in a recent talk that apparently flu vaccines are one of the most effective interventions against MIs. Yeah, didn't know that before. And so this is one study that my colleagues at the University of Pittsburgh and I have been working on in order to see differences in sleep patterns and rest activity rhythms in people living with HIV compared to those without HIV. And so this is a very much collaborative effort. The PIs are Dr. Patel, who I believe most people in this audience are familiar with, and Dr. Bernard Makatenge, who is the chief of infectious diseases now in University of Pittsburgh, and Stephen Smagula, who did a lot of the rest activity rhythm analyses that I'll be showing you. And so both people with HIV and without HIV were recruited for this study. People with HIV were adults and were eligible to enroll if they had viral suppression, a CD4 count greater than 300, and we're on stable antiretroviral therapy for the past year. They underwent 1 night of home sleep apnea testing with a watch PAT device in order to gather their apnea-hypopnea index, which we operationalized as 4% for this study, and also underwent 14 days of actigraphy. This is an example of some different measures that I'll be pointing out to you in the next table. And so you can see in the top left illustration, this is a representation of a normal rest activity rhythm. So you can see the activities counts plotted on the y-axis and the clock time noted on the x-axis, the time. And so you can see that in a very sinusoidal pattern, that you have an increase in activity, and then that decreases to a lull to virtually zero. And again, cyclical pattern up, down throughout. And so the y-axis here, you'll get a measure of amplitude. You'll also get a measure, and that's represented here in this lower left column, where you can see that the relative amplitude is blunted when you put the cosigner model on top. You can see on the upper right figure how instead of having a clean lull in between these peaks of activity, there's more bleed in, and so there's more noise, and so there's in this lower pseudo F statistic here, you can see that there's more bleed in, that you can not as well differentiate the periods of high activity with low activity, and so that's what. So you would prefer to have a high pseudo F statistic to indicate a more robust rest activity rhythm.
We're just out of curiosity, if you're comparing multiple individuals, right? These are just individual traces, I assume.
Yeah. So this is like just one person for a few days, yes.
But just because I don't understand activity as well as I should, but let's just say you have 2 people that you're comparing side by side.
Yep.
The activity score, is that specific to that individual and has to be normalized? Or are they directly comparable between the individual and individual two?
So what we
Does the absolute value mean that something when you're comparing the two, you have to scale it?
Yeah, I mean, so there are some measures that kind of get around that. So there is so people living with HIV, they do have much more sedentary activity, and so that kind of plays into the robustness of the rest activity rhythm. So there is,
but independent of HIV, if we just take 2 normal people.
yeah.
I don't, Dr. Stroll and I are normal, but you know, but like, you know, if I score 8,000 activity points on that score, is it the same if he hits 8,000? Is that a true comparable absolute scale across individuals, or is it?
So you want to use the relative amplitude, which is what we did in this study. So there is like an absolute amplitude of like how high you're going, but then there is also kind of like a baseline that you're comparing against, and so you do want to look at that that difference in order to really measure the difference in the robustness. And what we did as well is you kind of have to measure it. So he has a whole code on R that he can explain much better than I can, of how the parametric as well as the non-parametric measures kind of overlay here. But so there's some metrics in the actigraphy that we used that we could derive just from the mean measurements, and then there are some like the relative amplitude, the daily stability, and the pseudo F certificate that really uses that superimposed cosigner model.
Is that pseudo F statistic what's in red or in black?
So these two examples are the measures of the pseudo F statistic. So the higher one has a more robust reactivity rhythm where you have more activity and then more of a lull. Whereas this one, you have more of a bleed.
And then we don't deploy actigraphy enough to really get into the weeds on it, but there is an opportunity to do that. And then this particular tool, this actigraphy tool, is this the Respironics one? Is this the one no longer available?
Yes.
So that's the big thing. And the people who use this regularly have not been able to agree on any uniform standards. They give you a choice, and they always say you have to just figure out your own values. But I think the major thing what you're showing is what do they have? Their lowest activity and the highest activity. What's the robustness of that difference? And then rather than the area, there you go.
So, so I do have the absolute measures in my manuscript, but here I just wanted to highlight the differences between the two. So interestingly, in this study, we didn't see differences in the mean nightly sleep duration or the 24-hour sleep duration, but we did see a significant difference in the mean daily nap duration. The frequency of naps were similar between the two groups, but people living with HIV tended to have longer naps on average compared to those without. And then when we took a look at their sleep regularity measures, we found that they were substantially different between the two groups after adjusting for covariates. And so if we take a look at the standard deviation of the nocturnal sleep duration, we can see that they have a much greater standard deviation, meaning that they're not going to sleep consistently for the same length of time. We also saw that in regards to their bedtime as well. And we also saw that here with the standard deviation of midpoint as well. So they were having a greater range of times they were going to sleep, of getting up, as well as their sleep midpoint and the amount of time that they were asleep for. They also had a lower pseudo F statistic, meaning that their periods of inactivity did not have that strong difference between their periods of activity, of peak activity. And we can see that this also manifested as a lower relative amplitude in people with HIV compared to those without. And then the interdaily stability, which is a measure of the variance of physical activity to inactivity over the course of several days. That was also lower in people with HIV compared to the people without. And this held for univariate analyses, but also after adjustment for age, sex at birth, race, education level, unemployment versus employment status, smoking and alcohol use, as well as the AHI. We also took a look at measures of their sleep and activity timing. And so the sleep point you can see is delayed in people with HIV by about 40 minutes. And then when we take a look at their activity measures, we can see that they have, they kind of get going later in the day, and they have their peak activity later in the day as well.
You have to define that.
Sure.
These guys, if you have a sine wave, and you have a mesor, which is the nickel.
Yep. So this up mesor, this is the get going time. And so this is, and so you can see here that the measure of the HIV positive people, they get going about almost 3/4 of an hour later than people with HIV. The acrophase, which is the measure of the peak activity, also similarly deferred as well. And then the down mesor, which actually I need to update this this figure. This was also delayed as well. And you can see all of these are delayed by almost 3/4 of an hour. And so there are many risk factors for why this may be. So one may be that HIV directly impairs circadian biology. So if you take HIV or that's related virus, the simian immune deficiency virus, and you infect mice or primates, you'll see that the suprachiasmatic nucleus becomes impaired, and you'll see that they have more dysregulated rest activity rhythms as measured by less sleep activity and more activity during those lull periods, and so they have less robust rest activity patterns, just in the nature of doing the infection, and even if you control that infection directly just to the brain. Apart from direct biological mechanisms, you also have differences in their social and environmental interactions, and so there's something called as the social Zeitgeber theory of rest activity rhythm patterns, in which the social interactions that you have with the community help to keep you on a more regular sleep-wake cycle, because there's different social obligations that you need to do, different people that you're going to see, and people who have greater stigma and greater social isolation, because they don't have those regular interactions, will tend to have less robust rest activity patterns. There's also different medical reasons and other sleep disorders that could be playing a role. So you certainly have HIV specific medications that impair sleep quality and sleep efficiency, which may make people with HIV more prone to try to catch up on sleep during the daytime in order to kind of replete the poor sleep that they're getting at night. They are also at higher risk of smoking, alcohol, and substance abuse, which can directly impair their sleep quality, as well as directly impair their rest activity rhythms. And they have different environmental factors that also may impair sleep quality, such as unstable housing, nocturnal light, noise, and these type of things. And so there's a variety of consequences of disrupted rest activity rhythms that have been shown in the non-HIV population. And so people who have more disrupted rest activity rhythms are at more risk of depression, anxiety, and metabolic syndromes. None of those studies have yet been done in people with HIV, though, so we'll see if that continues to hold true, but I would expect it to. In this study, they took a look at the cognitive function of people with poor daytime sleep behaviors, such as frequent daytime napping behaviors. And they compared how those sleep behaviors were associated with cognitive performance. And so there is a spectrum of cognitive performance in people with HIV, which is called CAND. And so we can see that in people who had HIV, the PLWH here, you can see that that these people had a much lower cognitive score if they also had poor daytime sleep behaviors. And this appeared to be dose dependent, if you will, with increasing burden, their cognitive score also declined.
What's the metric for the DESB?
I don't. So it wasn't the Pittsburgh qual. It wasn't the Pisky.
Yeah, I'm just trying to, I'm trying to map it out. So all this sort of stuff. I bet it's the same. Studies of medical students show that if you had sleep disturbances, medical schooling 6-7 times more likely to be impressed with your H4. Sleep disturbances, pre-diabetes.
Yeah. Yeah, I would say that's actually a really good analogy.
Yeah.
Yeah. And they certainly also play a role in, getting, metabolic
Right.
consequences as well. So I think
Right.
pre-diabetes is actually a very, very good analogy. When we measure objective sleep measures, we do see a signal in several studies that people living with HIV have shorter sleep duration. And they generally tend to get around 6 to 6.2 hours of sleep, depending on the study that you're referencing. And so this study was done in 2012. In San Francisco, and I will say that this population did have a high burden of having active HIV infection, half of which had received an AIDS diagnosis, and so certainly there was that factor, but I think that there have been other studies as well that have shown this to be true as well. There was a recent study out of the UK, the POPPY study, which didn't show any differences in sleep duration, but they did show higher incidences of insomnia and poor sleep efficiency. And so shorter sleep duration may actually have biological consequences. And so this was a study that we did using the MAX cohort, using polysomnography defined measures of total sleep time, in which we took a look to see if sleep duration had any effect on T lymphocyte counts. And so I will say that this was a fairly non-sleepy population. And due to the limitations of the NOx A1, there was a paucity of slow wave sleep that we were able to see. But apart from that, you could see that with total sleep time, the amount of CD4 T lymphocytes really isn't really substantially different from people who have a short sleep duration, less than 6 hours, versus an intermediate versus a long. These are virtually similar. But when you take a look at their CD8 T cell counts, they do look like they are highest in the people with short sleep and are lower in the people with more typical sleep duration and with long sleep duration. And this ratio is important because it manifests as this CD4 to CD8 ratio. And it's thought that people who have a CD4 to CD8 ratio less than 1 are at higher risk of having non-AIDS comorbidities, such as increased risk of diabetes, heart attacks, kidney disease, etc. And so what we can see, pretty clearly in the literature at this point is that obstructive sleep apnea seems to be extremely common in people living with HIV, no matter by what measure you're using, whether that's the ASM criteria or the CMS criteria. And so people living with HIV seem to have sleep apnea at higher rates than the general population, and also of greater severity. And they also seem to have sleep apnea at lower BMIs. This was a study by our very own Dr. Patil back in 2014, in which they've looked at sleep apnea prevalence and severity between people with and without HIV, and also took a look to see if that prevalence and severity was impacted if it was different if by ART status. And so this study had a very, very high prevalence of sleep apnea in all the 3 cohorts, with it ranging from 70 to 80%, depending on the subgroup that was analyzed. But it was striking that people living with HIV had a high prevalence of sleep apnea despite having a lower BMI compared to the control group. They also appeared to have greater fatigue, 25% versus 7% between from the HIV group compared to the HIV negative group. And so, so here you can see that the difference in sleep apnea presence is higher in people with HIV compared to people without HIV. And then you can also see that the severity is more severe in people with HIV, and that's been shown in this study and in multiple studies as well. Interestingly, the presence of antiretroviral therapy didn't have a difference in the severity or the prevalence of sleep apnea in this study. And so there's been, a lot of hypotheses as to why people with HIV seem to be at higher risk for having sleep apnea despite having a lower BMI. And so there's been several studies that have investigated if the pathophysiological differences that people with HIV have. Yeah.
So,
And so one hypothesis has been that people with HIV, because of their antiretroviral medications, have higher rates of lipohypertrophy, which lipohypertrophy, which will distort their upper airway anatomy and make them more prone to having sleep apnea. Protease inhibitors tend to be the biggest risk of this. And so this study sought to evaluate if the AHI differed by protease inhibitor duration, with the hypothesis that the longer that you're on a PI, the higher risk of lipodystrophy you have, and so the higher your AHI would be. However, there was no significant association found between the AHI and protease inhibitor duration, as you can see. And the only predictive factor that they could find between the AHI was the BMI.
so that's the study we did.
You actually did, I know.
It was a little bit counter to this one in the sense that when we did a secondary analysis, we excluded people who had had any exposure to heart therapy, compared those to, who had some exposure. And so those that had any exposure to heart actually had a higher prevalence of sleep apnea compared to those that never ever had exposure to heart. Questions, can that be replicated in a larger sample size because it was fairly small?
Yeah, and that's the thing that with all these HIV studies, that they tend to be on the smaller side, unless you can have something like max, but even the ones that came out in the early 2000s still had a pretty low cohort, because I think you could only use 2 study sites out of
Right.
Yeah.
Right. But I think now you have that larger data set.
Exactly, yeah.
So you could probably go back and ask that question, right? Because that was a better sampling strategy.
Yeah.
And see if that association holds up or not.
Yeah, I think that would be a great study, actually. And so this study also wanted to assess if the upper airway anatomy was different in people with HIV compared to those without. And so they actually measured the upper airway using MRI. And you can see here that it's a very small sample, right, of 9 versus 11. But people with HIV seem to have a similar measure of their upper anatomy volume and their tongue volume and their tongue fat content between the two groups. If anything, there was a signal for a lower amount of tongue fat content in people living with HIV. However, the other values seem to be very, very comparable.
Okay, good job. They did everything. Still did.
And then the same group out of California, they also wanted to assess differences in endotypes between people living with HIV and without HIV. And so they took these people into the sleep lab. So they all had a baseline sleep apnea study in order to make sure that they had sleep apnea prior to coming in, and so then they underwent a research polysomnogram. And so they have a protocol which can evaluate these different pathophysiological measures. So initially at the onset of the study, they have people at the optimal pressure that they can measure their ventilation at the holding pressure that they call pheupnia. They then subject the participants to a series of rapid pressure drops in order to measure the ventilation passive, which is where collapse starts to occur, and then the peak crit is also measured at that time as well, the pressure where the critical closing pressure occurs. They then decrease this further to assess the point of the ventilation where arousals occur. And then can also gather the loop gain as well from dialing down or dialing up.
So, look at that, you go down, right, you go down there, and that goes with that little insert there, and you have a peak flow in every given pressure. Then you draw a line through, and you got that peak flow. Then you notice that there's also, when they first drop it, there's a little lower ventilation that comes up. That's your response.
Right.
Obstruction. So that's almost like your recruitment, and then they relieve it, and they look at the overshoot of ventilation compared to the baseline ventilation at 10 centimeters of water. And then they look at the undershoot afterwards, right?
Right.
And then they look at drop to complete apnea, hold it for a little bit, and then dial up, measure loop. But that's how you do it if you were going to do it. How do we train our? It is sleep technician meeting, right? It is sleep technician. How do we do our sleep technicians to learn how to do that? How do we teach fellows? That's the first.
I think you're only going to be able to do this in a research kind of setting, right?
We're a center of research.
Yes.
I got a peak grit machine.
Okay.
It's like Mickey Rooney, you know, you got a stage, you got a piano, we got a show. Okay, I'm just saying. You're not, wherever it is, you're not in Dubuque. I don't mean in Dubuque.
And so for all of these measures, they had similar measurements for the pheupnia, arousal, passive, active, and loop gain. So all of these measures were similar between the two groups.
And all I say was defined as more than 10 or 15 or something.
I will double check. I know they use the ASM criteria, so they use 3% of the rows.
I mean, that's disappointing. So
It is, right? It's very
It's disappointing, but not surprising.
well, but you got to measure it. You sit there, I've been writing about this and talking about this. And attorney said, oh, for individualized therapy, here you go, it just blows
Yeah,
out
yeah.
of the water.
Well, I mean, it doesn't detract from individual therapy, right? You know, it detracts from group therapy.
Right.
We can't make
Right.
assumptions between HIV and non-HIV groups, but, right, there's obviously large intra-individual healthcare out there, but you can still use a personalized medicine approach, but I think it just, right, it probably just tells you that the common pathway.
Right, so you can probably say that people with HIV are a vulnerable population that should be screened. But the actual treatment, you probably can't personalize it to their endotypes.
Good. I mean, it's gonna be a lot of work to do that. Some of that work is being done in Columbus and in the extremes. You look at the 90th percentile on the top and the 10% below, you see whether there's CPAP or not. So that's,
But those are gonna be population.
yeah, you need big groups. Good. I'm just thinking about actionable traits.
Yeah.
That's my new term.
So another a vote for similarity between these two groups. So they wanted to see if there was differences in the risk of high blood pressure between people with and without HIV. And you can see that in all groups, whether HIV positive or negative, there was a higher risk of high blood pressure, and it didn't seem to be additive. There was no interaction between HIV and sleep disorder breathing syndrome. So overall, I hope that I've convinced you that poor sleep health is very common in people living with HIV. And they have many risk factors that predispose them to poor sleep quality and disrupted rest activity rhythms. Although sleep apnea seems to be more common in people living with HIV, the underlying physiology appears to be similar between people with and without HIV, independent of HIV status.